case, follow-up case. But for a NICU case, one maybe can restrict to a focused examination, as Dr. Suja also mentioned, and the first case presentation. Otherwise, both were very well presented. Thank you.
Thank you, sir.
Okay, so is my screen sharing visible?
Yes, ma'am.
Yes.
Okay. Please interrupt me if my slides get hung up or if I'm not audible at any point of time. So we had two different case presentations. One was a stable growing preterm neonate and one was a sick neonate who had a very stomach course. So you will be having a lot of questions. We also have a lot of feedback, but that can happen later. We'll go on to the OSCE session now. We have a set of 10 OSCE questions, very simple, straightforward questions, but where answers have to be fine-tuned. So the first OSCE for the day. So a term baby was delivered by emergency LSCS due to abruptio placenta. The neonatal resuscitation chart of the center had the table shown below. So apart from a routine chart, this was a resuscitation table which was given in that particular center. So the questions are, what is a depicted table? What do you call it? What are the types of Apgar scores which are used now? And what is a full form of combined Apgar score? So can we have the answers in the chat box if you're ready? So what is a depicted table? What are the types of Apgar scores used now? And what is a full form of combined Apgar? So we'll go ahead with the answers. So the table which is shown in the figure is an expanded Apgar score. So expanded Apgar score is recommended currently by the American Heart Association. So apart from if a baby has a 5-minute Apgar, which we routinely document, of less than 7, then AHA recommends that you have to document the 10-minute, 15-minute and 20-minute Apgar also, which is called as the expected expanded Apgar score. So 5 minutes less than 7, then you will be going ahead with 10 minutes, 15 minutes and 20 minutes. Apart from that, this will also have the events that are happening. That means you will be just doing a checklist. Like at 1 minute I was giving oxygen, at 1 minute I was actually giving PPV, at 10 minutes I have intubated the baby, at 10 minutes I also had to start the baby on chest compression. So where you just put a check mark, it is called as an expanded Apgar score. Now what are the types of Apgar scores which are currently used now? You can actually unmute yourself and can give the answers also if you're interested. So somebody has given the full form of combined Apgar score. So we'll go on to it. So the types of Apgar scores that we are using currently are the conventional Apgar score, where we have the 6x4 table where you have 0, 1, 2, and you have all the full form of Apgar. The expanded Apgar score is what we saw now, where you will be expanding into the 10 minute, 15 minutes and 20 minute Apgar score, and you will be putting a check mark on the events. The specified Apgar score is actually a part of combined Apgar score. It is actually the Apgar full form only, but you continue with the interventions. Unlike conventional Apgar score, you don't stop your interventions. For example, in breathing, there is some chest rise, there is inadequate chest rise is what you document. So that is called as a specified Apgar score. The combined Apgar score is actually scoring for the intervention. So in expanded, you just put a tick mark, but in combined Apgar score, you give a score also. for CPAP, oxygen, mask and bag ventilation, intubation, neonatal chest compressions, and exogenous surfactant and drugs which are used. So this is the combined UPGAR scoring system. So in combined UPGAR, there will be one combined score and there will be one specified score. Specified is the normal UPGARs without stopping the interventions. So the maximum score for the combined UPGAR will be 7 and the maximum score for specified UPGAR will be 10. So then you give a total UPGAR of what on 17, what is the UPGAR score of the baby. So let's go to the next question. What is being shown here? So this is a device. What is being shown here? I'm sorry, I have to go back for your answers. Okay, most of you have given the right answer. It is a continuous closed suction device. So it is a continuous closed suction device. Now let's go into the questions. So you have already answered this. This is a continuous closed suction device. Mention some components of VAP prevention bundle. So this can be a theory question also for you, VAP prevention bundle. So I'm waiting for answers for VAP prevention bundle. Very good. Somebody has mentioned hand hygiene, sterile suctioning, ET tube care. Anything more? Anybody wants to add anything more? VAP prevention bundle. If somebody asks you to give 10 points on VAP prevention. Head and elevation. Early extubation. IV site care. Oral hygiene, very good. I think we have covered most of the points. So let's directly go into the answers. So this is what is given by WHO in prevention of VAP in the NICU. So it provides 4 main components. One is general care. General care, as you all mentioned, hand hygiene, head and elevation, and preventing gastric distension. Because whenever there is gastric distension, there is going to be microaspiration, which is going to happen. There is going to be reflex and microaspiration. And there will be atelectasis in the lower part of the lung. So these in the general care. In oral care, timed oral care, that means you won't allow secretions to pool within the oral cavity. I hope all of you know about oral immunotherapy. We're not going to go into details. And gentle oral suctioning. Because the more vigorous oral suctioning that you're going to do, you're going to cause mucosal trauma, which is going to encourage bacterial proliferation. Suctioning, very importantly, in WHO's perspective, separate catheter for oral and ET suctioning. Selective suctioning, that you will suction when you are when you think that there is an endotracheal tube block, when your ventilator graphics are showing the presence of secretion or there are visible secretions in the endotracheal tube. Otherwise, you are not going to routinely suction the ET tube. Routine saline flushing is not recommended. For every suctioning, you don't have to flush saline. Please remember, in units who are using closed suctioning, they use flush to clean the catheter, not the endotracheal tube. So don't confuse between both. Do not reuse oral catheters. Always discard closed suctioning devices whenever possible. In ventilation strategies, minimize ventilator days. Avoid sedation and muscle relaxants as much as possible. You have to provide analgesia, but not sedation or muscle relaxants. Removing condensate from the ventilator circuits. Preventing accidental extubation. So minimizing ventilator days, but at the same time, you have to prevent accidental extubation, because when a child is accidentally extubating, there's more chance that the pooled oral secretions are aspirated. Second, when you re-intubate in an emergency scenarios, there is more chance that you're going to do it in a less optimal way. Having unit policy of extubation and intubation. So this is a general idea. There might be even minor points on VAP prevention bundle. Now let's go into the next OSCE. So this is very simple. The first question is, What procedure is demonstrated here? Okay. So somebody has smartly answered. So UVC or UAC, we don't know because they're just showing a catheter which is being inserted. The second question is, so if it is an umbilical catheter being inserted, I'm not telling you venous or arterial, what is the ideal umbilical catheter size for a term and preterm neonate or whatever weight cutoff that you have? How do you choose your umbilical catheter size? So somebody has given a number 3.5 and 5. That is correct. But any weight cutoff? Okay, let's go to the next question also before we go into the answers. What is the ideal position of an UVC in an X-ray? And the last question is what is the ideal position for an UAC in an X-ray, umbilical artery catheter in an X-ray? Somebody had mentioned the size of catheter as 1 and above. I have not seen a one size catheter so far. So UAC high is T6 to 99, low is L3 to L4. And what about UVC? UVC T6 to T9, it will be almost in the heart. Okay, so let's go to the answers. As I said, this is an umbilical catheter insertion. It could be an artery or a vein. The ideal size for UVC, this is from Cloharty and the WHO guidelines. For a less than 1.5 kg baby, you are going to use a 3.5 French catheter. For more than 1.5 kg baby, you're going to use 5 French catheter. Earlier, when we were trainees, there used to be a lot of numbers. Like a strange book will give that we can even use a 8 size umbilical venous catheter. But now there is no ambiguity. 3.5 and 5. Less than 1.5, use a 3.5 French catheter, and more than 1.5, use a 5 French catheter. For umbilical artery catheters, standard is 3.5 French catheters, though some books mention that you can use a 2.5 size catheter for a less than 1 kg baby. But this is what we practically use, 3.5 French catheter for umbilical artery catheterization. What is the ideal position of an UVC in X-ray? Never confuse on this. It is T9 to T10. Ideal position of an UVC in an X-ray, according to Cloharty, it is T8 to T10. But yeah, T6 to T9 is also the right. I mean, you just have to see that it does not cross T11 at any point of time. So T9 to T10 for UVC is actually fixed. No confusion on that. Ideal position of UAC in an X-ray, high position it is T8 to T10 and low position it is L3 to L4. Now these numbers are the ones which are given in Cloharty and Stark's Manual of Neonatal Care. Now this was not a question, but roughly quickly going through the formulas, you know that there is a Dunn chart which is separate for umbilical artery catheter and umbilical venous catheter. For umbilical artery catheter, there are two formulas, Wright formulas and Shukla formula. So Wright formula is for a less than 32-week baby and Shukla formula is for a more than 32-week baby. For UVC, again we have a Shukla formula irrespective of the gestation. You would see that it is exactly half of the umbilical artery catheter insertion. And there is Valleys and Gomez method where you just measure from the shoulder to the episternum, umbilicus to the episternum, and then measure the depth of the body half from the bed of the baby. So you don't have to remember in detail about Valley and Gomez method, but Shukla formula is a very most commonly used one, and many units use Dunn charts also. Now let's go to OSCE number 4. So this is everybody's favorite question. So you know that it is a human milk fortifier, and it is actually mentioned over there. So the first question is, what is the current recommendation for human milk fortification? And what are the different types of human milk fortifiers? And what are the different strategies for human milk fortifiers? We'll wait for your answers. So what is the current recommendation? Which baby are you going to use? Don't bother about the company, be it a Lactodex or Prenan or anything. What are the types of fortifiers? What are the types of or strategies for fortification? And what is the current recommendation? Which baby are you going to use? Good. Somebody has given a gestational cutoff less than 32 weeks. You will start it when the baby reaches a feed of 100 ml per kg per day. Very good. Somebody, one of you have mentioned about the strategies: standardized, individualized, and targeted fortification. So let's go into the answers. So what is the current recommendation for human milk fortification? Ideally less than 1500 grams and less than 32 weeks, but many units use for 1500 to 1800 grams also when a baby is born less than 34 weeks. What are the types of human milk fortifiers? We have liquid and powder form. In India, liquid form is not very easily available. And we have bovine based and human milk based. You know, the Leonlacta MMF which is available. Fortifiers are also available. What are the different strategies for human milk fortification? We have the standard HMF therapy, we have the targeted HMF therapy, and we have the adjusted HMF therapy. So, because of lack of time, let me tell you what is standard HMF therapy. That is, you will have 4 sachets, 200 ml of milk is what is standard. So, irrespective of how concentrated is the mother's milk, you're not bothered. So, you'll be having 4 grams to 100 ml. That is one sachet to baby. Once a baby is 100 ml of feeds. What is targeted HMF therapy? Is you will make HMF and you will measure using spectroscopy. You will measure the protein content of the milk. You will increase a HMF concentration until a baby is able to receive 4 gram per kg per day of proteins. So, if the mother's milk is dilute, you will be adding more of HMF so that the baby ultimately receives 4 gram of protein per kg per day of protein per day. Now, what is adjusted? This is what you call as individualized HMF therapy. Adjusted is the other term of individualized HMF therapy, where you check the milk also and you check the blood urea nitrogen of the baby also. And then you have a target for the baby's blood values, and then you increase. If the baby's protein intake is less, then you will be increasing the HMF fortification. So that is about HMF. Now let's go into the next OSCE for the day. So a term unit was brought on day 16 with features suggestive of community acquired pneumonia. He was intubated and ventilated in PTV mode. He required MAP of 12 with FiO2 of 70%. His arterial blood gas shows pH of 7.307, PO2 of 51, PCO2 of 54, bicarbonate of 26, and base excess of 0.3. So the question is, calculate his oxygenation index, and what will be his AADO2. So this is a formula based OSCE. I have given you the FiO2 of 70%. He's on PTV mode, but we have directly given you the MAP of 12, and you have his complete blood gas. So what will be his oxygenation index and what will be his AADO2? So very good. Somebody has come with an answer for oxygenation index. It is actually 16.4. And what will be his AADO2? Okay, somebody has given an answer for AADO2 as 370. When I calculated, it came to 394. There might be mathematical errors. So the formula for oxygenation index is MAP into FiO2 divided by PaO2 into 100. There is some confusion regarding whether you to use this 100 or not. So see, if you are using FiO2 in decimals like 0.7, then you have to bring the 100 into the formula. If you are using a 70%, then you don't need that 100 in the formula. So when we calculated, the oxygenation index was rounded off to 16. And this AADO2 came to 394, which definitely means anything more than 250 is abnormal. So this baby is actually having a lot of problems in his lung. Now let's go to the next OSCE. So this is an umbilical artery waveform of a fetus over subsequent scans. So A was the first scan and B, C, D, E, F for the subsequent scans. So what is being demonstrated here? You can have a look at the scans. In the sequential scans, what is being demonstrated here? And now let's go into the questions also. From what gestation umbilical artery Dopplers can be performed, or when you can start interpreting your umbilical artery Dopplers? List few other Doppler studies which will help in predicting outcome of the pregnancy, and which will be the earliest Doppler change that can be done to predict placental insufficiency. So there are three questions. From what gestation umbilical artery Dopplers can be performed? List few other Doppler studies of the fetus which help in predicting outcome of the pregnancy, and which will be the earliest Doppler change that can be done to predict placental insufficiency. Okay, for the Doppler pattern, few people have responded that it is REDF, resistant flow, reversal flow, reduced flow has also been mentioned. Okay, very good. What are the other Dopplers that you can do? Umbilical artery, ductus venosus, and aortic isthmus Doppler. Very nice that you also, or you're also aware of the aortic isthmus Doppler. And which is the earliest finding that you can find is somebody has given a right answer. It is uterine arch notching. Yes, MCA Dopplers can also be done. Okay, so let's go into the final answers. From what gestation umbilical artery Dopplers can be performed? The earliest time you can do is 24, but the ideal time that you can do it is 26 to 28 weeks. So you can start interpreting your umbilical artery Dopplers. If somebody asks you for a single answer, then it is 26 to 28 weeks of gestation. Second trimester scan, umbilical artery reversal, reduced flow, they have no meaning at all. List few other Doppler studies which will help in predicting the outcome of the pregnancy. Uterine artery Doppler, ductus venosus Doppler, MCA Doppler, and somebody has rightly mentioned we can even include the aortic isthmus Doppler can also be mentioned in this. And which will be the earliest Doppler change that can be done to predict placental insufficiency? Uterine artery notching. Whereas from umbilical artery and ductus venosus, you start interpreting them from 26 to 28 weeks. Uterine artery notching can be found in second trimester, starting from 16 weeks onwards. That notching should not be present after 24 weeks of gestation. So persistent notching after 24 weeks is a sign of impending placental insufficiency or preeclampsia. Now, in this slide, you can actually say a baby's placental insufficiency or resistance progressing. Now, you have a normal Doppler here, then you have a reduced Doppler, then you have something here called as an ADF, where there is absent end diastolic flow. There is some reversal which is having, and here you are having a complete reversed end diastolic flow which is happening. Okay. So with that, let's go into the next OSCE. Pardon me for a second. Okay. So now we have OSCE number 7. So this is a pulmonary graphic of a term neonate on PTV mode of ventilation. So please have a look at the graph. This is a pulmonary graphic or of a term neonate on PTV mode of ventilation. The questions are, what graph is it? What is being depicted by the arrows there? And what will be your intervention? So you have to know what graph is it, what is being depicted by the arrows. So if you want to have a look at the image, and what will be your intervention. I will be waiting for your answers on your intervention. What will you do for this baby? So very good. All of you have given a right time. So it is a flow time graph is being seen, and both terminologies are correct. Auto peep, which happens because of air trapping. And yes, we have got the right answer. Somebody has mentioned allow more TE. T is expiratory time. So let's go back to the graph. So this is a flow time graph, as you all know. So it is a real time scalar graph where flow is on the y-axis and time is on the x-axis, which is understood. So you can, if you're very good with pulmonary graphics, you can see that this baby is on a pressure control mode of ventilation. And this is the inspiration and this is the expiration. You will see that the inspiration or the inspiratory air has started coming in even before the expiration is complete. It's not complete. So you won't be able to see pressure here, but we'll know that there's some air trapping is happening over here. So this is called as auto peep. In the pressure graph, you will find that the peep is slightly more than what you had set up, and the delivered peep also will be higher. So this is an indication of that your TE, you're not giving adequate time for the baby to breathe out. And as someone rightly mentioned, you have to increase your expiratory time to allow your baby to empty his lungs before you refill in air. So we'll go to the next OSCE, which is the 8th question for the day. So everybody will be like, oh, this question is so simple. So the questions here are, what is being demonstrated here? What will you do if a child fails the test? So what is being demonstrated here, and what will you do if the child fails the test? Yes, that the first question was, please be sure it is auto-acoustic emission. It is not ABR. ABR will require leads. This is auto-acoustic emission. This is auto-acoustic emission. So what will you do if a child fails the test? So for that, okay. So what is that testing sequence called as? It is called as two-tier testing. So you all should be thorough of the universal hearing protocol, hearing screen protocol. Okay. So in an Indian scenario, there will be a lot of retesting which will be happening, but let's see what is ideal. So what is meaning demonstrated here? As a part of universal hearing screening, this baby is undergoing an autoacoustic emission. So what will you do if the child fails a test? So in India, what is recommended is a two-tier testing. So ideally, what a two-tier testing is means all babies will be undergoing a OEE test. So all babies who are born well baby or sick baby, so they will be undergoing an OEE test. If the OEE test fails, then the child has to undergo an ABR or BERA. Okay. Now, what will happen? What they say is for a sick baby, if a baby has a lot of risk factor, for example, NICU stay, ventilation, asphyxia, severe neonatal jaundice, or the baby has received drugs, there is family history, they will be directly going to ABR or BERA. Okay. But within this two-tier testing, so this should be done within 1 month, and this should be done within 3 months. And by 6 months, the baby should be have received an ENT assessment. And if the baby is deaf, he should have started on hearing aid and therapy also. But because we are resource limited country, we have retesting within this also. So what some units follow is they do the first OEA within 2 weeks, then they retest the baby. If OE fails, they retest the baby at 6 weeks. If both a OE fail, then they do the ABR by 3 months of age. And as mentioned, you have to get an ENT assessment by 6 months of age. ABR or BERA is acceptable when it is done after 34 weeks of corrected gestation. So once a BERA or ABR has come as like abnormal, then it is very important that you send them for a proper ENT evaluation. What an ENT will do, they will check whether there is any problem with the middle ear or anything. They will also evaluate the baby further with more higher hearing tests. See, if ABR is abnormal, that doesn't mean that clinically the baby does not have any hearing at all. So they will try to do behavioral audiometry test and all. And a baby child may be requiring scans to look into his cochlea, into his auditory nerve, and they will be preparing the baby for a hearing aid when he is awaiting his cochlear implant surgery. So two-tier testing, ideally, it means that we are doing OAE and then by 1 month and ABR by 3 months. But within the OAE, there are units which practice, and it is accepted also that within the first 2 weeks you do one AE, and before the 6 weeks you repeat another OAE, and both fail, you have to send the baby for ABR. Now this is OSCE 9. This is also a simple OSCE. So what is being demonstrated here? Milk banking. So what procedure is being done there? Pasteurization. So they are showing a pasteurization. What are the two types of pasteurization? Okay, so what we are seeing is a breast milk bank, and a pasteurization process is going on. So let's go into the questions. What is the storage recommendation for the final product? At what temperature, for how long can you store it? The second question is, what is the threshold bacterial count for raw milk? And the third question is, what changes are observed in human milk after pasteurization? I want to specifically know what is lost in breast milk after pasteurization. Yes, there are two types of pasteurization, which is not actually displayed question there. There is a holder method and there is a flash method. what most of the machines equipments available with most of the human milk banks are Holder method only. In Holder method, you lost some of the proteins, which we'll be discussing. So that is why people are now experimenting or making trials with flash method or the high temperature, low time method of pasteurization. And there is something called as ultra fast pasteurization also. Everything with an effort to retain the nutrient value of the milk. Yes, we have to store it minus 20 degree and we can store it for 6 months. Anything on what is lost in the breast milk after pasteurization? So minus 20 degrees Celsius for 3 to 6 months. Remember, when it comes to breast milk, when you are talking about milk storage, mother's milk storage, a different guidelines say different, like how long can you freeze it, how long can you keep it in the freezer, like that. So some say 2 weeks, some say 3 to 6 months, some say 6 to 12 months. I don't want to confuse you, but why is there difference in the numbers is because what type of freezer they are mentioning. So few textbooks give very clear explanation. So if you are storing it in the freezer of your routine refrigerator, where the freezer is part of the general chamber, then it is only for 2 weeks. If you are storing it in a separate freezer where it is a double door freezer and you don't open the freezer for anything else, but it is a horizontal freezer, then you can store it for 3 to 6 months. The 6 to 12 months come only when you are having a separate vertical freezer. This is because the changes in the temperature with each opening and closing activity is very less in a vertical chamber refrigerator. That is why different policies give different timelines. For the purpose of milk banking, when mothers are storing milk in their house, you have to collect it within 2 weeks. Once pasteurized, you have to store it within your milk bank for 3 to 6 months, be it a horizontal freezer or a vertical freezer. So jot it down somewhere why there is a difference in the guidelines. So 3 to 6 months for a pasteurized milk, 3 to 6 months in a routine home domestic refrigerator. Only if you have a separate vertical refrigerator and mother is storing her own milk, it is for 6 to 12 months. Threshold bacterial count for raw milk. You see, after pasteurization, we don't want any bacteria in the milk at all. But if the raw milk has a lot of bacteria, anyway, the toxin will be in the milk. So even if you pasteurize and your culture is coming out sterile, the toxin is going to cause problem to the baby. So for that reason, you have a threshold for bacterial count for raw milk also. So you have to send the raw milk for testing. And if the test report comes that this raw milk have more than this number of bacteria, you have to discard all the entire batch of milk. So for that, 10 to the power of 5 colony forming units for all bacteria. And if it is Enterobacteriaceae or Staphylococcus aureus, it is 10 to the power of 4. And what changes are observed in the human milk after pasteurization? I simply remember it as all else. So lactoferrin, lysozyme, the live leukocytes, live bacteria are actually slightly less in the pasteurized human milk. IgA levels are also slightly less in the pasteurized human milk. Rest of the components are almost retained in the breast milk. Now let's go to the last ASCII for the day. This seems to be a long ASCII. So look at the image carefully. You all will be able to answer it in a GIF in a GIF. Cranial ultrasound for a 26-week neonate at 72 hours of life. This baby required resuscitation at birth, inotropes in the first 24 hours, and is on mechanical ventilation. You won't have any confusion with the primary diagnosis, but a very specific diagnosis. So somebody has mentioned grade 4 IVH. Any other answers? Grade 4. Okay, because grade 4 has a specific definition, right? So let's go back to the image now. So this is the left side, this is the right side. You see the blood is filling the entire chamber. The ventricles are completely filled. but there are not much of echogenicity. They look symmetrical. The echogenities are symmetrical in both the areas. The ventricle is dilated. Here also you are having a bleed, but it is going into the ventricular cavity, but the ventricle is not so much dilated. So I would say that it is right-sided grade 2 IVH and in a left-sided grade 1 IVH. Now let's go into the classification system also. Okay. So this is a question for this imaging. What is being demonstrated here as we discussed? What are the two grading systems currently used? And what is the screening protocol? So just mention the two scoring systems which are used or the grading systems which are used for IVH that you are aware of. Volti, very good. Volpi and Papelet. Yes, it came out as volleyball and Papelet. It's Volpi and Papelet. Which is ultrasound, which is CT? So Volpi is ultrasound and Papelet is CT scan based. So that is a small, even I use it terminology again and again. So Papelet criteria is actually based on CT. So here is what they mention about the ventricular dilatation. So grade 2 is IVH without ventricular dilatation, which I actually mentioned over there, but it is actually only for CT scans. Volpi criteria actually mention the percentage of ventricle which is filled with pellet. So less than 10%, 10 to 50%, and IVH occupying 50% of the ventricular area. And if you have a periventricular venous hemorrhagic infarction or a cystic periventricular leukomalacia, then you can call as grade 4. So here there will be hyperechogenicities along the ventricle, or there will be hypoechogenicities with cyst formation. We didn't have both of them, so I would have to, on the left side I would have to document it as 50% of grade 3 of intraventricular hemorrhage. The right side probably grade 1 to 2. So we all are very comfortable with using these terminologies, but for ultrasound you have to grade based on Volpi criteria, which actually says less than 10%, 10 to 15%, or 50% of the ventricle which is filled. Now, even in the case scenarios, people were in the clinical case discussions, they were mentioning about ultrasound. So we quickly go through it. The first scan for an extreme preterm neonate is 48 to 72 hours. First of all, who are we going to scan? Less than 32 weeks, less than 1.5 kg is the Indian guideline. And if a baby is less than 34 weeks, then if the baby has a stomy course, you have to get an ultrasound done. 48 to 72 hours, first scan. Second scan, end of first week to second week. Third scan and fourth scan, you can either 3 to 4 weeks. This can be skipped, but fourth scan at term equivalent age, you have to definitely get plan. So 3 mandatory scan. Third scan at 3 to 4 weeks can be done. And an early scan in the first 24 hours when a baby is very sick, like in the second case we had, you can do an early scan immediately after birth also. And if anything is abnormal, you're not going to wait till 40 weeks corrected gestational age. You can repeat scan at 1 to 2 weeks interval as per clinical decision. This is a short note on the IVH prevention strategies. So there are medications which are proven role like antenatal steroids, vitamin K, and treatment of significant PDA, not prophylactic PDA treatment. In intensive care, we have to avoid rapid infusion of colloids and hyperosmolar solution, avoid large fluctuations in BP, maintain normocapnia, and golden hour management where ventilation, surfactant administration, UVC insertion all happens within the first 1 hour. Nursing care, head and elevation, avoid elevating the legs during diaper change, avoid procedures that will increase cerebral venous pressure. Example, avoid doing deep suctioning. Pain management, cluster care, and prevent accidental extubation. So with this, we are coming to the end of the OSCEs. You all would have known all the answers and the questions in the scenario. Hope it was useful in revising what you already know and organizing your thoughts. Thank you. Over to Dr. Nidhi and Dr. Sankalp.
Thank you for wonderfully moderating the session, ma'am. I think both the fellows presented the cases very well, and I would like to thank everyone for taking out their valuable time to join the session. With this, I would end the session today. Thank you, everyone.
Thank you, ma'am. The OSCEs were really very nice and they were quite useful. And your explanations were very, very exhaustive, ma'am. Thank you so much. I'm sure fellows would have learned a lot from the OSCEs.
Thank you, Dr. Sankalp.